Hi, my name is Major Andrew Fisher. I'm currently a general surgery resident at the University of New Mexico School of Medicine in Albuquerque. I was previously a PA in the 75th Ranger Regiment, where I served for 9 years. And while I was there, I was able to help implement a program utilizing fresh whole blood at the point of injury. Additionally, I was also a prior combat medic and paramedic in both the civilian world and in the United States Army. Today we're going to go over how to perform an ABO confirmation test using an Eldon card. First thing we're going to do is clean the edge of the finger that you prefer to use. Prior to doing this, please have your patient or donor fill out the ABO card here. Need a little bit of water in your pipette and squirt just a drop of water in each circle. Okay, next you're going to take off the protective cover there. Go ahead and press this up against the patient's skin. And once you see a drop of blood, you'll take each of the Eldon sticks, just enough to cover the top of the Eldon stick, and you're going to apply it in the center and just slowly in an outward direction, kind of circle covering to the edges. Make sure you only use one Eldon stick per circle. This is repeated all 4 times. If you end up with a little extra blood, just wipe it off as needed. Okay, once that's complete, go ahead and you can dry off your donor, your patient's finger there, and we'll wait for these to result. They are labeled anti-A, anti-B, anti-D, and your control. When interpreting this, you want to make sure that you use the information packet that comes in the Eldon card to help interpret these findings. Based upon what I'm seeing here, we can see that he has no anti-A, he has no anti-B, he does have anti-D, and our control is normal because it doesn't have any coagulation. Showing this, it appears that he would be O positive. Is this correct?
Yes.
So that is a basic overview of the Eldon card and how to perform an ABO confirmation test. Hi, we're back. We're going to go over the donation process at this point. Indications that you might want to do a blood transfusion kind of vary based upon changing guidelines. So always refer to the Tactical Combat Casualty Care most up-to-date guidelines, the Joint Trauma System website, or the Deployed Medicine website for the most up-to-date indications to perform a blood transfusion at the point of injury. Before starting any intervention on any patient, we want to make sure that we take a good set of vital signs. So we're going to make sure we have a blood pressure. We're going to have a pulse oximetry that has both the pulse and the SpO2, and we make sure we take a temperature. Once that is complete, we can go ahead and move forward with our donation process. All right, so we're going to start our donation process here. Just like any sort of process where you do an IV, or you're going to start saline lock or whatever it may be. You want to apply a constricting band on the upper arm. You want to make sure it is nice and tight. You can have your patient clench his fist or her fist to see if you can get a little bit of veins to pop out, a little bit easier to see. You want to make sure you find a vein that can at least accept a 16 gauge needle. So most likely you're going to find that in the antecubital fossa. So we're going to start looking here. We can see several veins that are appropriate size. We're going to make sure we take a proper antiseptic swab and clean the area. Prefer that you use chlorhexidine or something similar beyond a normal alcohol prep. Once that is complete, just go ahead and let that dry. In the meantime, we can talk about the blood transfusion bag. This type of bag that most likely you'll find in your fresh whole blood collection kits comes in aluminum packaging like this. You can look for the expiration up here. It says July 24. You can also find it down here where it says the date of expiration. Go ahead and open it. And inside you'll find the blood collection bag in another clear wrapping. Just go ahead and take it out of that. And these are both disposable. You do not need to keep them. You can go ahead and throw them away with the rest of your trash that you have from treating your casualty. Once your chlorhexidine or whatever antiseptic that you use, go ahead and place a clamp just a few inches below the needle here. You want to take your bag. You want to go ahead and make sure it is appropriately placed below the patient's heart. In this situation, we're going to place it onto the floor. That is an appropriate place in the pre-hospital setting. So don't feel that it is an unsanitary technique to place the blood collection bag on the ground or in the dirt, wherever you may be. Next, we're going to go ahead and uncap the needle. And this is a 16 gauge needle. You want to make sure, just like any sort of IV, you want to go bevel up. I would typically, just like any sort of IV, I kind of pull the skin taut. And I enter about a 45 to 30 degree angle. Once you get it in, you feel you're in a good place, you go ahead and let go of the clamp and blood should start to flow. You can see that the blood is flowing into the bag. At this point, I can go ahead and I can leave the constricting band on. I'm going to have my patient, my donor, help me by holding the needle in place while I go ahead and tape it down. You don't need a lot of tape here. This is mostly just to keep it in place while the blood collects. And I can see down here that my blood is starting to fill the bag. This bag has citrate in it, which prevents clotting. So what I want to make sure is I get this citrate mixed throughout the blood as it collects into the bag. Now, I don't need to continuously rock it back and forth, but I do need to every now and then make sure that it is rocked appropriately to ensure mixing is done correctly. Usually it takes about 5 to 10 minutes to fill the bag up. And we can talk about the appropriate ways to measure for a full blood bag at this point. Now, if you are in an austere setting, typically you're not going to have scales available, but maybe you do. If you have scales available, that's fantastic. You want to make sure you weigh, it weighs approximately 580 grams, plus or minus 10%. That's approximately 450 milliliters, plus or minus 10%. Next thing I want to do, if I don't have that available, I can use what we call usually beaded cable tie, and I can put this to 6.5 inches. Most of the kits that come available, or that are available commercially now, do come with a marked area on the beaded cable tie to where I need to place it. So I'm going to place this around the long axis of the bag, and I'm going to just simply snip it down, slide it down until it gets to the mark, and then I will, that will restrict the amount of blood that can go into the bag, therefore not allowing it to overfill. Overfill can be hazardous because it could cause clotting into the blood bag. It could overall cause too much of the blood versus the citrate ratio. So I'm going to go ahead and place this around the bag now. You don't have to place it immediately, but sometimes it does help if you feel more comfortable doing that. This goes around the long axis. All right, and we are full already. So it doesn't take that long as you have a good sized vein. It is properly placed, and that needle kind of lays flat in there. and you have a good amount of area to where the bag can drop to in order to fill appropriately. So I see once we're full now, we can go ahead and disconnect this from the patient. First thing we're going to do is let's undo our constricting band. Next thing we're going to do is I'm going to take the hemostat, place it over. I'm going to remove the tape. And I'm going to then place a 4x4 over the top of the needle. And simply remove it. And your donor should be able to hold that in place. You can just place another piece of tape just like you would for any other IV or blood draw over the site. Okay, let's talk about a little bit about how to prepare this from here. You want to be able to tie 2 knots in this line close to the blood collection bag. You can also protect your sharp here to make sure you don't stick yourself. There's no one way to do this. I've seen it done a number of different ways. As long as you're able to get the knot, 2 knots in here, that's the goal. It's easier if you tie the proximal knot to the bag first. All right. We'll take this off. We'll talk a little bit about, these blood bags and if you don't have a beaded cable tie, how you can tell if it's full. If you lay it flat, it should have some dimpling on the side. It should be firm but not taut. If you hold it up in the air, you should still see air fluid line in there. And overall, if you do it several times, you kind of get used to that weight, how it feels. But that's probably the least reliable way to do that. Okay, the only thing left to do now is to cut between these 2 marks, these 2 knots, and we will then be able to move on to the transfusion part. Very important. Make sure you fill out your blood bag label, okay? So make sure you have your donor battle roster number, the ABO type that he has. So if I didn't have it available, I would use the Eldon card to confirm. But if I have a roster with me, I'll be able to, I'll know what type he is. If this patient is a low titer, so it's important that if we talk about, is this patient a low titer or not, whether this person can donate to everyone versus a type-specific or group-specific blood transfusion. And it's collected by, so who you are, the time it's collected, who's going to administer it, and the time that is administered. So those two can remain blank for now until it is handed off to the person who collected, because it may not always be you who collects it and does administration. So it may have to go to someone else who can then provide that blood administration for you. And our final thing we're going to do is we're going to go ahead and cut between these 2 knots. You'll notice that the blood is left inside of the line here. Previously, it was thought that it would be best to let this run through. However, now it's probably best to go ahead and just leave that in the line, tie your 2 knots, and then cut. And finally, we're going to take a last vital signs for our donor here. That includes, again, a blood pressure, a pulse oximetry with both pulse and SpO2, and our temperature. All right, we're going to begin our transfusion process at this point. What you'll need is a simple IV starter kit. During any sort of intervention that you may do on a patient or casualty, you may ask someone to collect the fresh whole blood for you. During that time is when you will go ahead and start the IV. If you have to collect the fresh whole blood yourself, you may have to come back and start the IV on your patient. Go ahead and put the constricting band high up on the arm. If your casualty can participate, have them go ahead and squeeze their fist back and forth like that. All right, once you identify a nice vein, go ahead and prep the area. Again, using something like chlorhexidine is preferred over using an alcohol prep. You can use anywhere from a 18 gauge, 16 gauge, even a larger 14 gauge if you feel comfortable doing that. Just make sure that whatever you're doing, whatever size gauge you want to use, that you have an acceptable vein that will accept the angiocath. Okay, big stick, 1, 2, 3. Go ahead and make sure that you got good flow, backflow. I see blood there. Go ahead and flush it. And then you can go ahead and secure it with any means possible, whatever works best for you. There's no specific best way to do it. Okay. Okay, make sure you move all sharps to the appropriate place so you do not cause any sort of injury to yourself or others. And next thing we're going to do is we're going to talk about how to prep your blood bag and all the appropriate measures to ensure that you're doing this safely. So there's a couple different parts to this. One, we have our drip chamber, all right, or administration set. Now you may find several different types are out there. You can even find ones that are just have a single line versus having the 2 ports at the top. This one has 2 ports at the top, so we'll talk about this. These are for, one for saline or any sort of, you have to use sodium chloride or you can use plasma light. But also the other one then is for your blood. When using whole blood, you don't actually need the second port, but based upon how your medical direction prefers, we're going to go ahead and use it as though it is required during this session. First thing you're going to do is make sure that all your clamps are closed. So you have total of 3 clamps on this one, one below like you would have a normal IV set, and then you have the 2 above that are for your blood and for your saline. Go ahead and spike your saline. You want to go ahead and turn that on, and you can kind of fill up your drip chamber there just like you would any other IV set. Go ahead and turn on the bottom so you can kind of get it to run through, and that is now primed. Go ahead and now turn this one off. Okay, so saline off. I'm going to go ahead and hang this so it stays out of my way. The next thing I'm going to do is I'm going to take my blood bag. I'm going to do a timeout, okay? Now, a timeout is used in medicine when we make sure we're going to do an intervention that has potentially high risk and adverse outcomes. So I'm going to make sure that this is the right patient, okay? I'm going to make sure that this is the right donor, okay? And then we're going to make sure that we have the correct blood type. So I know that based upon my blood bag label, especially if I collected it, I know that I drew it from this battle roster number, and this is the ABO type. And I know this also because I also have the Eldon card if I need to go ahead and check that. Now, if I don't have a roster, I'm going to go ahead and do an ABO on my patient also. So make sure you're doing donor and patient for an ABO if you do not have a pre-made list that has been generated for you. Okay? Once I do that, I want to, if possible, I want to make sure someone else is there with me to confirm that this is the right patient, right blood type, and we're doing it for the right reasons. Okay? Given that's complete, we'll go ahead and get started. I want to go ahead and just, these peel back on these blood bags. They don't pull off, they peel back. And you're going to expose the this inner part here, just like a regular IV. You're going to go ahead and spike it just like you would. First thing I'm going to do once I get this hooked up is I'm going to run it through this pressure bag. Now I'm not going to turn the pressure bag on, I'm not going to inflate it, but I am going to get it prepped because I want to make sure that I run a little bit of blood through my patient to make sure there's not going to be a reaction before I pump this up and rapidly infuse this transfusion. There are a lot of different types out there, including different types of pumps. Just make sure you're familiar with what your unit has and learn how to use it. Okay, now we're set. All right, I'm going to now turn the one on the blood. I'm going to roll it down so it can run. I'm going to go ahead and see if I can turn this bottom one on just to make sure it flows. All right, so now I can go ahead and hook it up to my patient. Go ahead and start running. You can see the blood in here. You can go ahead and prime it a little bit more if you want to. The thing about this tubing specific is that it has a filter in it. And that's important, that you cannot use just regular IV line with this. You have to use specific blood transfusion tubing because of this filter in here that can catch any sort of small clots, very, very tiny clots that you won't even be able to see. And so we want to make sure that that's safely done and we can administer this blood to our patient. Now, as my patient starts to receive the blood, I'm going to watch for a few different things. I worry about some transfusion reactions. The most common transfusion reaction you're going to find is going to be the non-hemolytic febrile transfusion reaction. This is where your patient gets a slight raise in his temperature, and this happens because I'm introducing foreign material into the patient. So that's kind of common thing for it to happen. It can be treated with just simply Tylenol. Other things I worry about are allergic reactions. Now, if a patient has an allergic reaction, I'm going to see it as very similar, almost exactly like someone who may have a regular allergic reaction or even anaphylaxis that may happen. So I'll see hives, itching. If it's anaphylaxis, someone may have some trouble swallowing, trouble breathing. And then from there, the most concerning reaction that I may see is an ABO incompatibility, which means that I gave blood of the wrong type to the patient. If that were to happen, patient may have back pain, fevers, chills, muscle pains, and if the patient is peeing, they will have a decreased urine output. For that sort of situation, you need to stop the blood transfusion immediately and begin resuscitation with crystalloid. An allergic reaction, you can sometimes manage that with Benadryl. And overall, if it has a decent response, you can go ahead and continue. And that's based upon the fact that if I have a dying patient in front of me in hemorrhagic shock, I need to weigh the pros and cons of giving a blood transfusion to someone who has a potentially allergic reaction versus them dying from bleeding. So take that into consideration and also take guidance from your medical director upon how to address those sort of situations. All right, so it's now been a few minutes. I'm going to go ahead and get a set of vital signs to see how my patient's doing and make sure we don't have any sort of adverse events happening. So again, we're going to get a blood pressure. We're going to go ahead and place on a pulse oximeter that again will give us a pulse and SpO2. And I want to make sure I get a temperature. Once that's done, I can go ahead and if it's all normal, I can, normal given that, a patient may be in hemorrhagic shock, but I don't see any increased temperature of concern. I don't see any sort of signs or symptoms of a transfusion reaction. I can go ahead now and I can pump up my pressure infuser to give blood at a more rapid pace. Now be mindful of, if you are going to be transfusing blood to casualties, you may have to use multiple different units of blood to treat your patient. Just make sure that you're aware of that. If you're using one type of blood, then it should be safe to continue using the same set. If you end up switching blood types, say if you start off with like a low titer unit and then you may switch to an A, or you start off with an A and you switch to a low titer, you may consider go ahead and flushing that line appropriately with your normal saline. So as we go through here, I'm noticing that my bag is starting to deflate a little bit, and that's because as my blood runs in, the pressure overall decreases. So I want to make sure that as I'm pumping this up, there is an area between 150 and 300 that I want to stay in. There's different gauges based upon the different sort of pressure infusers. Make sure you don't go over into the red area. You may have an increased chance of causing damage to your blood cells and the other blood products. So just make sure you stay in that safe range for the pressure infuser. Another thing you may want to consider is if I plan on doing this multiple units of blood for my patient, I could consider removing this portion, this extension here, and then just hooking the line directly up to the IV, or I'm sorry, the catheter itself. Or if I have a much shorter just saline lock on the back of it, I could hook it up that way. So as we go through, I'm continuing to monitor my patient for any sort of adverse events. I'm also looking for my patient to respond to the blood transfusion, and I'll continuously refresh the vital signs as needed to make sure that I see this response that I need. And that's going to help guide me overall on how often or how much blood I need to transfuse to my patient before he or she is evacuated from the battlefield. Okay, so our blood transfusion is coming to an end here. We're almost complete. We're going to continue pushing and increasing the pressure on the infusion bag. And as we come close, I'm going to start preparing for what's going to happen next. So if I feel that my patient's responded appropriately and now does not require any additional blood transfusions, again, refer to the Tactical Combat Casualty Care Guidelines, to the Deployed Medicine website or the Joint Trauma System website for the most recent up-to-date guidelines and what is an indication of a successful resuscitation. So I'm going to make sure I still have my saline here hooked up, still have plenty in there that I can go ahead and run through this, through the line here. I'm going to go ahead and get another set of vital signs to make sure that we're following appropriate protocols to make sure my patient is safe and not having an adverse event. Again, that can consist of a blood pressure, SpO2, and heart rate, and a temperature. Okay? All right, we're almost done with our transfusion. Some rapid infusers do kind of lose the end, the bottom portion of this blood. So when that happens, I go ahead and I just take it out. And I'm just going to squeeze it manually to make sure my patient gets as much blood as I can give to the patient, because clearly it's indicated, and blood is a very, very scarce source on the battlefield, and so it's important that we try to use as much, all the blood in the blood bag as we can. Again, don't squeeze it too hard, because you do have the chance of causing damage to the red blood cells and other blood components. So just nice steady pressure. And this goes if you don't have a pressure infuser and you just have to go ahead and squeeze it manually. Just nice even pressure around the bag. All right, so that concludes our blood transfusion. So now what do I do? So I just do the opposite. So I'm going to take this roller, I'm going to roll it up to stop the blood transfusion. I'm going to turn on the saline. I'm going to make sure that's flushing, and I'm going to flush all this through as much as I can without giving too much of the saline. And we know that crystalloid resuscitation can be harmful to our patients, But giving a small amount is not harmful and just helps overall clear the line in case you need to go ahead and transfuse more blood, or just to make sure that your patient gets as much blood as they can. And once you are satisfied that the patient has received the cleared the line appropriately, go ahead and close the roller clamp on there. Go ahead and close the roller clamp here. You can go ahead and disconnect the IV or the administration tubing from the saline lock. And from this point, you can go ahead and flush the saline lock appropriately and prepare to treat your casualty for other issues. All right, now that our transfusion is complete, we're going to do one last set of vital signs. Again, blood pressure, SpO2, heart rate, inner temperature. Once that's complete, the transfusion and process is complete. Thank you for joining us. Again, my name's Major Andrew Fisher, and happy to have you along on this training video. If you have any questions or concerns, again, please refer to the Tactical Combat Casualty Care Guidelines, the Joint Trauma System website, or the Deployed Medicine website. Thank you.